We're at the American Heart Association meeting. You know, Rocket AF has been one of the trials that we've covered a lot. You've read about the different trials and the sub-studies. We've got one here at AHA that's very interesting, and I'm talking to Dr. Jonathan Piccini, who is an assistant professor of medicine at Duke University. What are you presenting here specifically, and then let's talk about the trial.
Sure. So what we're presenting are the management and outcomes of major bleeding events in patients treated with Rivaroxaban or warfarin in the Rocket AF trial.
What did you find? Well, first, before we go there, remind us about Rocket AF and some of the basics of that overall trial.
Absolutely. So as everyone knows, warfarin was the only anticoagulant for many, many decades. Now we have several target-specific anticoagulants to choose from. Rocket AF was a large international double-blind, double-dummy, non-inferiority trial, which demonstrated that Rivaroxaban, which is a direct 10A inhibitor, is non-inferior to warfarin for the prevention of stroke and systemic embolism. And importantly, treating patients with Rivaroxaban leads to less fatal bleeding and less intracranial hemorrhage. However, despite those advantages and ease in dosing, clinicians have concerns. What if my patient develops a major bleeding event on one of these new medications? How do we treat that patient, and what are their outcomes? Are they predisposed to a poor outcome because we don't have a quote-unquote antidote for these new agents?
And there's research being done on that new antidote, but until then, what have you found?
Right. So what we did is, in order to address this concern in the clinical community, we analyzed the patients who had an ISTH criteria major bleeding event. So those are bleeding events that lead to transfusion of 2 or more units of packed red cells, that lead to a drop in 2 grams of hemoglobin or more, or those that are associated with an important clinical site like the CNS or that are fatal. We analyzed 779 major bleeds that occurred over a median of 1.9 years. We found a similar event rate in the warfarin and the Rivaroxaban arms. The overall event rate was 3.5 major bleeding events per 100 patient years. And the first thing we did is we looked at how those patients were managed. And very interestingly, despite all of the focus and interest on complex coagulation products like PCC or prothrombin complex concentrates and other specialized coagulation factors like Novo-7, we found that the use of those specialized coagulation factors was very uncommon, if not rare, in Rocket AF. So, for example, only 4 patients in the entire Rocket AF trial who received Rivaroxaban were treated with a PCC, and only 9% of only 9 patients treated with warfarin were treated with a PCC. So, out of over 14,000 patients, only 13 received the PCC. And the use of other specialized coagulation products was similarly rare. When we looked at transfusions, we saw that numerically more patients treated with Rivaroxaban required packed red blood cell transfusion, but numerically more patients treated with warfarin received fresh frozen plasma. And then most importantly, we looked at the outcomes after a major bleeding event. So again, getting at the clinician's concern, what happens if they do bleed? How do they do at that point in time? And we saw no major difference in any of the clinical outcomes, including stroke or systemic embolism, the composite of stroke, systemic embolism, myocardial infarction and death, myocardial infarction, and all-cause mortality. No difference between warfarin and Rivaroxaban. And if anything, there may have been a signal that the patients treated with warfarin trended to doing better.
I mean, we know that there are a lot of patients who are not receiving some of these life-saving drugs, and this would seem to me to be a good excuse to say, hey, maybe you really should be thinking towards this because they are pretty safe. Right.
So putting patients first, the message always needs to be that patients who are at risk for stroke should be receiving a stroke prevention therapy. And then there's lots of options available to clinicians, and if there are concerns about a patient having a poor outcome if they have a bleeding event, the great news is that we can share from Rocket AF that there does not appear to be any difference in hard cardiovascular endpoints and all-cause mortality in patients who have a major bleeding event on warfarin or on Rivaroxaban.
That's really good. Thank you very much. And for more information from the AHA meeting, including Rocket AF, which you can see in Cardiol Source World News Interventions, I'm Rick McGuire, Editor-in-Chief.